Hello everyone, and thank you for virtually meeting with me. I'm Daphne Broadhurst, a clinical specialist with medical pharmacies in Ottawa. As some of you may be aware, there's been a surge in reported medication errors related to the use of infusion pumps in several of the LHINs. Today we're going to look at what some of the causal factors are that we've found on further investigation, and more importantly, look at some of the strategies about how to keep yourself and your patient safe when managing infusion therapy. We know that infusion pumps have been a game-changing technology that has allowed our patients to receive their prescribed IV therapy in the safety and the comfort of their own homes. And while I'm sure many of you would generally think that these pumps are indeed a blessing, you probably have had the occasional episode when you're having difficulty with the pump or when you get calls for frequent alarms that you may feel like this, that you may have be cursing that infusion device. So let's look at how we can bring it back and make infusion therapy and the use of IV pumps a blessing for our patients and our practice. And if you've ever made a mistake with an infusion, I'm sure you didn't wake up thinking, today's the day I'm going to make an error. We need to heighten awareness that infusion therapy is a complex therapy that can be prone to errors, as we can see in this data. We need to always be cognizant that infusion therapy is not a therapy that we can become complacent with. If you administer PCA, this is particularly at high risk. And if there is an error, your patient is at 4 times a higher risk of harm than with other medications. Every year, a publication comes out indicating the top 10 health hazards related to medical devices. It's crazy to see that with all of the medical device technology out there, that medication administration by infusion pumps was named the second highest hazard. And note the first place one, alarm hazards. Could be alarm fatigue related to infusion pumps maybe. And number 6, air embolism hazards, which also are a risk related to infusion therapy. So while we're using smart pumps, and they're great because they have that drug library with soft and hard limits and other forcing functions designed to reduce errors, but we have to remember that the pumps are only as smart as the user. And please know that while I may be referring to one type of infusion pump throughout this presentation because that's the one we happen to be using, in speaking with other clinicians, similar errors seem to be experienced with other brands of ambulatory infusion pumps as well. Now I want you to take a look at the pie chart on the right, which denotes issues related to smart pumps. Take note of that biggest piece of the pie. Concentrations are where most of the issues are, followed by pump programming issues. And you're going to see that this data is mirrored in the data we're going to be sharing with you. This is a report of medication errors and where they occur in the medication delivery process, not specific to IV therapy. It's a busy slide, but the main point is that if there's an error that happens in the last phase of medication delivery, and that's you administering the medication, there's a very low chance, like 2%, that it's going to be caught. And to make matters worse, this is the phase of medication delivery that is associated with the greatest harm to the patient. Smart pump technology can be part of the strategy to reduce drug errors when used for infusion therapy. They have the forcing functions and the constraints with the drug limits and the forcing of accepting entry values. But there's other strategies as well that we can use to support the safety features of infusion pumps, and we're going to be addressing those throughout the rest of this presentation. So why are we offering this educational opportunity? Unfortunately, we've seen an increase in the reporting of errors related to infusion pumps. In one home and community care region, an analysis of 22 errors related to infusion pumps showed that over half of the errors were related to drug concentration. And this is very alarming because it's where the greatest risk is, as a concentration can and has resulted in overdosing, for instance, up to 10 times the prescribed dose, as you're going to hear. And you'll note too that some of the other errors, wrong dose, wrong time, and in 2 cases, the pump wasn't started, which of course means that the patient's not receiving their prescribed therapy. In another case, it was the wrong medication. And also note that in about 3/4 of these errors that it is associated with PCA medications, and the others were antibiotics. So now let's delve further into some of these errors, and more importantly, learning from the errors. In one case, an order was written for IV hydromorphone. The prescribed rate was 0.2 milligrams per hour. Unfortunately, the pump was programmed at 2 milligrams per hour. The nurse left the home, and shortly afterwards, the son observed that the patient had long breaks between breath. He called his brother, who fortunately was a doctor, and sent him an image of the pump screen. And the brother immediately said to turn the pump off. And so there's a couple of lessons here. Obviously, there was an initial programming error, but the nurse did not catch the error, nor was there an independent double check done to intercept the error. And you may ask, well, how can you do a double check in the home when there isn't a nurse that can just come and view the pump? But take note of what the patient's son did. He sent an image of the pump screen to his brother. And at the time, I don't believe there was a documentation record to verify the pump settings. And think about how the error was eventually intercepted. It was due to monitoring of the patient by a family member, which points first to the importance of symptom assessment, particularly with a patient receiving PCA therapy, and secondly, to patient and family education, so they know the signs and symptoms of adverse events to report. In another case, a patient was receiving hydromorphone with a concentration of 4 milligrams per ml, and the order was changed to increase the concentration and the rate. The patient was sent the cassettes with hydromorphone 10 milligrams per ml. That's 2.5 times the previous concentration. The nurse changed the rate, but the patient reported afterwards that the nurse had difficulty changing the concentration, and in the end did not change the concentration. So the rate was changed to 1.8 milligrams as ordered, and you think that's great, it's the right rate. But remember, the pump was set to deliver the drug based on a concentration of 4 milligrams per ml, which equaled 4.5 milligrams per hour. So it's not a calculation that we see, it's built into the library, and this is where there's huge risk with concentration if we don't understand the implications of concentration for the rate to be correct. Yet another concentration error. The new cassette was administered, but the concentration change wasn't noted, leading to an overdose. And in another case, this time with antibiotics, a patient was prescribed continuous vancomycin. However, the pump was programmed in intermittent mode, meaning it was set so the patient only received 1 or 2 doses per day. Unfortunately, the patient had to be admitted due to subtherapeutic dosing. And in that root cause analysis, multiple gaps, of course, were found. There was no verification that the pump programming matched the medication label nor the prescription, and there were no independent double checks to confirm these. The family wasn't told what to expect when the pump runs on continuous mode, and there was incomplete health teaching to the family, and that teaching was not verified. Lastly, it was an unusual dosing, as vancomycin in these regions are typically ordered intermittently, i.e. every 12 to 24 hours, rather than continuously. Now, all of these errors are unfortunate, and sometimes they're tragic, but what's also tragic is if we don't learn from these errors. We know that when an error occurs, rarely is it the fault of one, but usually many gaps in the system. So let's apply the Swiss cheese model of causation to look at what some of the contributing factors to medication errors may be. In this model, there's multiple defense layers in our healthcare system designed to prevent errors. And if there's a gap at, let's say, the organizational level, that error may get through to the clinician level, but hopefully there's enough protective resources in place at that level for the error to get intercepted there. But if there is a gap at the clinician level, then the error may actually reach the patient. And if we haven't built any error prevention strategies at the patient level to capture that error, then harm may occur. Let's look at some of the breakdowns that may occur at the organizational end, where we hope that there's enough defenses in place to prevent an error or to have it intercepted at the organization level so it doesn't advance through to the clinician. So let's look at some of the gaps that have been identified across these medication errors. As we go through them, I want you to think about whether your organization has these safety strategies in place to protect both the nurses and the patients. So what was found is that some of the organizations had inconsistent policies guiding their safe infusion therapy and pump management. A red flag was identified where there was a lack of clear double check protocols. Some thought a double check was simply if you check that the bag matches the order which matches the pump by one person, whereas others thought if that one person does a timeout and then goes back and checks those same parameters, that was sufficient. A lack of continuity of nurses was also identified as a contributing factor, as the nurses often weren't familiar with the patient due to the rotating of nurses. Pump design was also identified as a contributing factor. We have urged the manufacturer of this pump to consider changing the pump interface so that the drug concentration is perhaps in with the other pump settings, which I'll discuss later. We had an issue with frequent error alarms, which didn't cause program errors, but did lead to cases of missed doses due to the pump stopping during an alarm and cases of over and under infusion related to the pump technology as well, of course, as other factors. We also identified that our pharmacy labels on the medication bags or cassettes did not have the same language as the pump, which could create confusion. And communication was a big issue, particularly with verbal or telephone orders. So these are some of the gaps which increase the risk of an error advancing to the clinician level. As most of the errors occur at the clinician level, let's look at what factors were identified that may be contributing to errors for clinicians. One was that policies and procedures may have been in place, but they weren't followed for double checks, as well as documentation of that double check. In one case, an outdated documentation form was used that didn't cue the nurse to do the verification of the programming. As well, not seeking clarification from the prescriber or reaching out to clinical experts, as in the case of the nurse who couldn't figure out how to change the concentration on the pump. Another factor is not understanding how concentration works in terms of mils per hour versus milligrams per hour, or understanding the safe doses of drugs. Another incident revealed that the nurse hadn't checked to see if there was enough medication left in the reservoir before the next nursing visit. This led to a delay in therapy while awaiting a nursing visit. Again, lack of verification of pump settings is a contributing factor. And as we saw in the hydromorphone overdose case, inadequate patient and family health teaching and documentation can lead to errors not being intercepted, as well as bypassing the drug library. For instance, if you can't find the right concentration, so you go in to find another drug that runs at the same rate, but at a different concentration, that will lead to an error. And a strong contributing factor throughout almost all cases is distractions. We've heard in a number of root cause analyses where the house was chaotic, family were talking, were yelling, the family and patient were urging the nurse to hurry up so they could get to an appointment, for instance. So those are some of the errors at the contributing factors at the layer of the clinician. The patient is our last layer of defense to prevent or intercept an error. In our investigation with the lens, it was found that the patients and/or family did not have sufficient written or verbal material to understand how the pump and therapy should work and what to look for and how to resolve a complication. The patients, of course, are also often in a vulnerable state, especially the palliative care population, which often means they're unable to advocate for themselves, so they rely on the clinician. So with so many potential failures or gaps in our healthcare system that could cause harm at either the organizational or individual level, how can we make infusion therapy safer for both our patients and nurses, as errors can increase both nursing and organizational liability? In the current patient safety culture, we need to take a look across our healthcare system to identify these gaps. We need to accept that errors will actually occur, and we need to fix this and stop them from getting through to our patients. Everyone is involved in safety, from administrators to nurses to pharmacists to pharmacy technicians to patients. I'm going to share with you some of the strategies that we've identified and implemented to help minimize the risk and or consequences of medication errors. We can't be naive or complacent with medication administration and think that errors don't happen. Errors are occurring, and every time you manage a pump, no matter how experienced you may be, you could be the next person involved in an error. If an error occurs, we need to make it visible. Report it so others can learn from it. Let that be the good thing that comes out of an error, which can be traumatic for both the patient and the clinician and the organization. If an error occurs, avoid the blame game in which the last person in the chain of care gets the blame. It is usually the nurse who's administering the medication, even though other caregivers may have had a role in the error. Acknowledge the person for bringing forward this learning opportunity. And because it's not usually the fault of one, involve everyone in the system to determine how a similar incident can be prevented and share your learnings with others, as we're doing here. For those administrators in attendance, what can you do at the organizational level? Do you have documentation tools for nurses to confirm pump programming at each visit, and is this part of your policy and procedure? Do you have detailed independent double-check procedures in place which clearly state how this is performed, and is there a place for this to be documented? How often do you provide training to your staff so that they are familiar with infusion therapy related policies? Do you have 24/7 access for your staff for resources related to infusion therapy and pumps? Do they have a helpline they can call if they're unsure of something? How often do you validate your staff's competency? I believe Accreditation Canada requires this at least every 2 years, although most nursing providers now do annual validation. In one southeastern Ontario region, contracted nursing providers are actually required to audit their nurses' documentation records annually to ensure compliance with pump verification. And I was also excited to hear that there was rumor of a potential requirement for contracted nurses to have formal certification in infusion therapy from a professional association such as the Canadian Vascular Access Association certification. At the pharmacy level, we have reconfigured our IV medication labels so the language on the label matches that of the pump. For instance, our label now uses the term lockout, similar to the term lockout on the pump to refer to how often the dose may be administered. In one root cause analysis, there was a question about whether the incident occurred in the morning or the evening. So we've now switched our clocks on the pumps to the 24-hour clock to reduce the confusion. In another region where we send out pre-programmed pumps, we now have a triple check process in compounding, whereby the pharmacist and 2 pharmacy technicians perform the double check independently, and it's also recorded on a log. We also now have stickers that we put on the medication cassette or bag to alert the clinician and patient to a concentration change. In the central Lynn area, a working group decided that would send out a new pump for any changes in concentration because of the high risk associated with concentration changes, which of course means a pump exchange pickup. In one incident, there was confusion between two pumps which were used, one being for keep vein open infusion in a pediatric case. However, since this incident, we've now advised against this practice. Let's look to the front line now, how you, the nurse, can prevent errors. It's so disheartening to hear in a root cause analysis that a patient erroneously received an infusion over a course of days, with no one catching that error until day 3, despite multiple patient-nurse interactions. One of the basic principles of medication is to ensure the rights of medication administration. Every time you, the nurse, sees the patient, whether in the clinic or at home, you absolutely must verify that the physician order matches the medication label and that the label matches the pump to ensure that the pump settings reflect the most recent order, regardless of whether you're the one who's setting the pump up or not. And I think this is just about the most important slide for frontline nurses. Please make sure that the drug and the concentration are right. With this particular pump's configuration, it's easy to see how this crucial step may get missed. The drug and the concentration are indicated in a top box where it tells the time. You can see it outlined in yellow on the screen, rather than down in the main body where all of the other pump settings are. There's advantages to that, but there's also disadvantages in that if the nurse doesn't take the time to read that box at the top and is focused only on the pump parameters, they may miss the drug concentration. And this is what's happening. Every time you go in to verify the pump settings or change a setting, always look up at this top bar to make sure that the drug and concentration are correct. You also don't want to end up in a situation where the pump stops because the cassette or medication bag was empty. Always calculate ahead to make sure that there's enough medication left in the reservoir to get the patient through to the next visit, unless of course the patient is performing their own reservoir changes. In one case, the pump was set for the incorrect time for the dose to start. If the pump is programmed in intermittent mode, you can program when the next dose is due. For instance, if you're starting an antibiotic infusion and the next dose is due in 8 hours, you can program that time. There was an error in which the time was right, but it was actually for the next day rather than that day. And so the patient missed critical doses of antibiotic. So please make sure that you check the time as well as the date when you're programming the next dose. And then once you start that pump, check again to make sure it says, in this case, 7 hours and 8 minutes is the correct time for the next dose due for the patient. If you've set up an infusion or reprogrammed a pump, check to make sure that the pump is running before you leave the patient. You may think it's common sense, but as you've heard earlier, there were 2 cases in which the pump was not actually started. When you press start, you'll be prompted to press yes to make sure you want to start the infusion. So before you put that pump in the waste pouch, check that the bar in the middle of the top line on the pump says running and is green, and that little light flashing on the top left of the pump is flashing green. And make sure your patient understands that this is how they can check to make sure that their pump is running as well. If the pump is in PCA mode, when you're recording the amount given, make sure that the numbers make sense. Do a critical analysis of these numbers. Do the number of attempts versus the amount given make sense? Does a patient perhaps need more education if there's a lot of attempts? Or do you need to reassess their pain management if there's an excessive number of attempts? As well, in one case, the nurse recognized that the bag shouldn't have been due to be changed as early. So she went in and looked at the delivery history on the pump, and it was noted that there were excessive clinician boluses administered, and the appropriate action was taken to prevent further incidents. Remember that patient whose son recognized that his parents' breathing was irregular? This is a reminder to all clinicians to always assess the patient's symptoms, particularly when they're on PCA, to monitor for perhaps signs of oversedation or poor pain management. In the same vein, always look at the whole picture. Check that the order matches the medication label, which matches the pump, and check that the patient is responding to that therapy as expected. Do the patient's symptoms match the patient's trajectory of therapy? If they're receiving an antibiotic, for instance, is that infection resolving? If not, you may need to contact the prescriber. And also check that the pump is programmed correctly to ensure the patient is receiving the medication as prescribed. We have worked with several of the LHINs and contracted nursing providers to develop a standardized approach to verifying and documenting pump program settings with every visit as well as pump programming changes. The nursing providers have found this to be an effective tool whereby errors have been intercepted because of this documentation. Make sure you're diligently completing this form. In the Southeast LHIN, this is a mandatory requirement, including administrators auditing these completed records to validate compliance. All of the forms, although they may look a little bit different in your region, require double checks, which we'll address again in a moment. The forms also prompt the nurse to verify pump settings, the volume remaining in the cassette, and that there's an extra cassette or medication bag in the patient's home, as well as to assess patient symptoms. Don't be complacent though when filling out these forms. I know no one likes to document, and it's easy to perhaps just copy the numbers and put check marks, but if you don't critically assess while documenting, you could be missing a crucial opportunity for you to prevent an error. Remember, errors can and do happen. One of the recurrent themes in root cause analysis of medication errors is disruptions. And you may come to accept working in a sometimes chaotic environment in the home. But with a culture of safety, we need to realize that it is critical that you control the environment you're working in as much as possible when you're managing an infusion pump. If possible, step into another room to reprogram the pump. I've actually had a couple of nurses tell me now that they will actually go out to their car to program the pump if they can't even hear themselves thinking, if the environment is just too chaotic. And if that's not possible, I urge you to caution others in the room to leave the room while doing this step. And if you can't do that, then adopt the speak aloud protocol. Advise those in the room that you're doing something that requires your dedicated attention to make sure it's done correctly. Then once the room is quiet and the television is turned off, advise your patient that you will be reading aloud the medication orders and the pump settings to make sure they match. It's very important that they not interrupt you while you're doing this. Then proceed to read each part of the order aloud and say the pump setting out loud. For instance, say aloud, hydromorphone 10 milligrams per ml, reading that from the order, and then say aloud, hydromorphone 10 milligrams per ml, reading it from the pump, and continue with the rest of the prescription and pump settings. This cues your patient not to interrupt you, and you're using multiple senses to process the information. So again, use strategies to minimize disruptions and use the speak aloud protocol. It is your responsibility to ensure that you have the knowledge, skills, and judgment to manage an infusion. Make sure you follow your organization's policies and procedures. And if you see any gaps in your protocols, advocate for change. You need to make sure as well that you remain competent. Even if you think you're a pro, participate in your organization's annual competency validation sessions and any infusion therapy in services. And most importantly, If in doubt about anything related to the infusion, such as programming the pump, use your helpline. Call the pharmacy or your nursing colleagues or office, or refer to the pump literature. Look online at the pump manufacturer's website. Just stop and take the time to learn how to do it properly. There's a wealth of information out there to guide you in your practice. At the pharmacy, we have quick reference sheets for both clinicians and patients. We have developed a patient education checklist that you can use to cue your teaching with patients on how to take care of their catheter in the pump and what to do if signs and symptoms of adverse events occur. It also indicates how to change your batteries or recharge the battery, whichever is applicable. Leave this in the home following your teaching with the patient for the patient's quick reference. Hopefully by now you've caught one of the key messages. Make sure you always check that the drug and concentration are correct when handling the pump. And in this culture of patient safety, also please don't be afraid to report errors. There should be no blame and shame. We need to learn from these errors so that they're not repeated. Learn from this quote: "A smart man makes a mistake, learns from it, and never makes it again. But a wise man finds a smart man and learns from him how to avoid the mistake altogether." In summary, we need to ensure that we have a safe infusion therapy system. Let's build in as many safety strategies as we can at the patient, the clinician, and the organizational levels to prevent and help intercept any errors. Thank you for taking the time with us at Medical Pharmacies to help build a safer infusion therapy system.